at least a way of gaining knowledge about older adults if the students want, or any population that's underserved or simply not discussed. What my participants all kind of shared is the general adult population does not embody clients across the lifespan. What was happening, although this is a lifespan program, honoring the lifespan, so the very young to the very old, the only focus was on the general adult population, so young adults. And they were saying that it did not embody clients across the lifespan. Theme 4B and 4C really speak to kind of the lack of addressing the needs of older adults. So lack of aging content and course availability, and lack of faculty interest and knowledge about older adults. I have an exemplar for sub-theme 4C. As a counselor, I'm not sure I want to counsel older adults. I think this ties back to the lack of discussion about older adults. It's almost as if there's this discomfort from both the professors and my peers to talk about older adults. Maybe they had a really bad experience with their grandparents, but also I get the sense that no one wants to own up to it. Almost like older adults have been erased from the discussion, but no one wants to say why. This participant statement struck me, because how can a population just be summarily erased from the conversation? How can that be? To me, this speaks to kind of this, again, a dismissal of a population that cannot be erased from, you cannot erase older adults. But here is a participant who is actually saying, look, I saw this happen in vivo. I see it happening in vivo in the classroom. We just simply don't talk about older adults. My fourth sub-theme, a lack of preparation for end-of-life issues. These participants in particular want this knowledge about end-of-life palliative care in the hospice movement. It takes a special kind of person to counsel older adults. One of the questions posed in there is who provides counseling for older adults. Hands down, all of my participants, with the exception of one, said social workers. And while, yes, to be sure, social workers provide a valuable resources for older adults, the purview of counseling older adults falls within psychologists, falls within counselors. It's ours. It's what we do, if we want to. So, but they automatically just assume social workers did. I don't want to get pegged as a counselor who works with older people, and I just don't see myself working with old people, but I sure hope a counselor is willing to talk to me when I get old. So, the getting pegged comment, this particular participant had said this throughout the focus group and then again during an individual interview. And I had pondered this and pondered it because, getting pegged is really strong. It's a very strong statement. So I queried her during individual interview. I said, well, would you feel the same way if your colleagues sent all of the adolescents to you? Would you feel pegged? Well, no, Susan. I mean, you know how much can be done with adolescents? So she gave herself away. And I did, and my whole purpose in conducting my dissertation was not to judge at all. I mean, I sat there and I kind of had my neutral face, but I really sat with her and I said, oh, okay. So basically you're saying that older adults, again, you cannot do X, Y, and Z with, but you can with adolescents. So you wouldn't feel pegged. So, and I let her sit with it. A few months afterwards, she had emailed me. And she said, you know what, Susan, I've been taking this course, and it had a component on counseling older adults. And I'm wishing I hadn't said getting pegged. That stayed with her as well. She said, I'm wishing I hadn't said that. She said, what I really meant to say is that I don't see how I can work with older adults. And it is because that knowledge hasn't been imparted to her. In other words, the process hasn't been normalized. It's okay. It's all right. You can do this. So, and the second quote speaks to, again, their need, because all of them provided a variation of this, except for one who actually wants to counsel older adults. They don't want to counsel older adults, but they know when they get older, gosh, they want someone to listen to them. It's real important. Summary, CIT's understanding of counseling older adults, hands down, they did not have like a fundamental understanding of counseling older adults. What they had was kind of, again, these misperceptions that hadn't been clarified for them. They were disinclined to counsel older adults. It was just too hard. Evidence revealed a tension as they realized the likelihood of counseling older adults regardless of their area of specialization. They came to that realization that no matter what, they're going to somehow be somehow serving older adults, whether they are working with children or adolescents or young adults. They want foundational knowledge about aging and counseling older adults for these three primary reasons, and that is, of course, to help their loved ones, their aging family members. They adore them, they respect them. Many had grandparents in nursing homes, and it was just breaking their hearts. And so I know that's a part of why they had such a hard time talking about aging. Clients being raised by older parents and grandparents, most of them already had clients like this. And to help families adjust to and accommodate for aging family members. My recommendations, these are just a few of my recommendations. Mine was the first qualitative study to examine the millennial generation of counselors in training, and also basically asking them questions pertaining to aging. So it was the first age-related qualitative dissertation study conducted. And I did so for all of the reasons that I shared with you earlier, but mainly because there's such, for me, a contradiction. Mental health students are trained, if not already innately, to be empathic, and to be empathic of persons across the lifespan, not just your particular population. Yes, you have a population you wish to serve, but you shouldn't dismiss or deny or negate the other populations that are involved in the lifespan. So my sense is that educators need to become sensitized to the reality of ageism and how it might affect mental health students and their older clients. The onus falls on educators to kind of put an end to the perpetuation of ageist stereotypes and the myths involved. Age-related stereotypes, and this is key, it goes hand in hand, need to be directly addressed in academic and clinical settings as they occur in vivo and used as teachable moments rather than deflecting or negating the impact of age-related stereotypes have on the recipient and bystanders. I had several of my participants give me examples of students who were interested in counseling older adults in their classroom, and the professor, for various reasons, either deflected the comments or would make a joke about it, and students would start kind of engaging in that same kind of behavior, and it was never addressed. So again, you have a perpetuation of this idea, this notion that it's okay to make fun of old people, or to at least use them as someone, portray them as a population that's not as important, especially in counseling, and that has got to stop. The myth that counseling interventions are less effective with older adults, coupled with the notion that older adults are resistant to counseling, needs to be overcome through coursework and clinical experience. My dissertation is chock full of empirical evidence that shows evidence to the contrary. Older adults will not resist counseling and counseling, and all we need to do is modify counseling interventions as we would with any population. We have to work with those symptoms rather than against them. So these are myths that need to be dispelled. The imperative of acquiring minimal gerontological competencies needs to be emphasized throughout the mental health education, regardless of anticipated student career paths. It needs to be woven into the multicultural competencies. We are becoming more and more interdependent, but I don't think we're talking about it. So I think we need to normalize and strengthen the notion of interdependence across generations. We're no longer kind of living as independently as we like to think. And so I think we need to start normalizing that, bringing that to the discussion in the classroom, in our homes. We just need to go ahead and normalize it so that students don't feel like they're talking about something unusual when they say, my grandmother's living with me. And that's okay. Or, it's one of those things where there's such a stigma, I think, of sharing these stories, and many of us are experiencing them. Expose mental health counselors and students to critical gerontology as only one way of bolstering critical awareness in educators and students of the marginalization of older adults. Doing so, exposing students to critical gerontology, the principles of critical gerontology, will help them identify unequal treatment towards older adults. Not exposing them to critical gerontology, what will happen is what I saw in vivo in my dissertation study, is my participants unintentionally perpetuated ageist stereotypes. They didn't mean to. They didn't realize they were even doing it, but they did it. Because it takes a conversation. It takes talking about, listen, this is an example of ageism. This is an example of sexism. Isn't that what we did with racism? We talked about it. My participants did not realize it. It's only at the end of my study when we debriefed that we start talking about it, because the purpose of my study was not to talk about ageism, although I knew that was at the root of it. But it's one of those where it just takes a conversation. Future research. Doctoral students. I provided clinical supervision for over 5 years at the University of Rochester to master's level students, both mental health and school counselors. Doctoral students play a huge role, I think, in socializing master's level students. But their kind of perceptions, their age-related perceptions and beliefs about counseling older adults has not been examined. So it would be, I think, interesting to conduct a study seeing how they felt. Also practitioners and faculty in general. None of that has been done just yet. Many of you might be familiar with Dr. Gerald Sue's work on microaggressions, racial, gender, and sexual orientation. This needs to be expanded, in my humble opinion, to include ageism, which he has not done. Ageism and discrimination. So it needs to be expanded to include ageist microaggressions, which not only cause pain and suffering for older adults, but what they do is they serve to kind of instantiate a distorted understanding of the aging process among younger aspiring counselors, and it could very well affect how they perceive aging and working with older adults, and primarily also because there's so much diversity in aging. And it's true, we don't all, and we will not all age the same way. And so it's kind of helping them expand their horizons and understand that there is diversity in aging. In 1969, Dr. Robert Butler was just an amazing elder-centered advocate, and he wanted to raise awareness about the aging population in the United States. And he said that a kind of attitude or a way of expressing ourselves as Americans may inadvertently perpetuate the stereotypes against older adults. He was the first person that coined the term ageism. And what he said, Dr. Robert warned that ageism might parallel racism as the great issue of the next 20 to 30 years. And he reminded us that we all don't grow white or black, but we all grow old, barring early death. And that's really true. I mean, the moment we're born, we are developmentally on track to aging. So it was with Dr. Robert Butler's work, with this phrase in mind, that I conducted my study. I'm so much on a mission to just kind of raise awareness and just simply, we're all going to grow old. Why don't we find ways of helping the oldest generation, of which we'll be a part of, age well in whatever way we can. So that's my mission. That's the end of my presentation. There are my references. I do have my limitations and strengths. I think I might have, well, I do have 5 minutes. Limitations. In qualitative research, usually small samples. Mine was extremely small, and it wasn't because I didn't try to recruit larger members. It was in part what I shared. I was a clinical supervisor for a couple of the universities in the Rochester area, and so my sample was going to be small just by virtue of that. So if anything, transferability in terms of other counselor education programs and CACREP accredited programs may not be as applicable. Selection bias, to be sure. Those persons in my study was, if you were going to participate in my study, you were going to spend a lot of time with me. So, and they knew that in the informational letter that I sent. So there could be selection bias. Persons who agreed to participate might be different than those who chose not to. Yes, sir.
So, I think it's an issue that study stage, but you had multiple sessions of your focus group that met?
We met for one session. Each focus group met for about a 90-minute session. And then after that, I transcribed verbatim all of the transcripts, and then we met individually. I met individually with each participant.
So just as a methodological question, is there a danger of contamination or bias because of the kind of questioning or the dialogue that took place in the focus group and then the follow-up in your, how would you handle that? Or how would you advise a student, for example, who was grappling with a similar kind of issue?
Two things that I did. I had a co-facilitator help me conduct the focus groups, primarily because this is an area of passion for me. And I am, as a qualitative researcher, I am to bracket my assumptions and my biases, and I did so. From the outset, I have a notebook in which I wrote down all of my biases and assumptions that I did have about my potential participants. My co-facilitator was someone who has absolutely no desire to work with older adults and was as objective as you can possibly be. So she sat there, and actually she was the one that would pose the questions so that I didn't necessarily ask leading questions. And so she was the one that kind of I utilized as my tool to be able to ask these kinds of questions and rein in the participants. These focus groups were very lively. There were women who were just ready to start talking. I fed them. We sat down, broke bread, and so it was a very kind of a laid-back setting. She, my co-facilitator, acted as kind of the guard to make sure that everyone stayed on cue. Afterwards, I debriefed with her. I also debriefed with my methodologist to ensure that I always kept my assumptions and my biases in check. I never, until the end, until I started writing my discussion, did I ever lend interpretation, other than to getting clarification from participants. It was hard. It was really hard. Another limitation I did have was positionality tension as a status as an insider researcher. And that is primarily as status as an insider researcher, is I did have knowledge about the program in which I was studying. I had knowledge about the professors that they were discussing. I had a lot of information that, again, it's difficult to listen to and hear everything that was being articulated and not already have kind of an opinion about it. So again, this is where I had to bracket. I had to meet with my dissertation committee and process through this, because I could not, as a qualitative researcher, although I'm positioned in the research, I cannot lend my perspective in the results. In anything that the participants had shared with me, it was only during the discussion that I was able to I was set free, and I was able to then use critical gerontology to analyze the data and what they were saying. So that was a very tense situation for me, one that I was prepared for, but nevertheless, it is a very kind of awkward situation, because they revealed information, and candidly, that has nothing to do with my dissertation, that speaks to sexism, that speaks to other things that are taking place educationally within this institution. So that caused a bit of tension. Yes, ma'am. Yes, and verbatim and manually. I didn't use in vivo. I just went ahead and did it. It's an amazing labor of love.
So both your focus group and your interviews went into your themes?
Yes, yes. It's the iterative process of constant comparison is what I had used. And my methodologist was a qualitative researcher. She had earned her degree from the Syracuse University. And so she's very much, yes.
That's where I went.
All right, so you so she, and Dr. Stephanie Waterman, and so she basically said, okay, Susan, we've got to sit down and really go through this. It's not a grounded theory study, but I certainly did use a grounded theory technique. I'm sorry? Dr. Stephanie Waterman. Strengths. I had, mine was the first qualitative descriptive study to capture age-related perspectives of the youngest generation of counselor trainees. And I think I did so in a way that's not easily assessed through questionnaires or survey. If I were to do my study again, or a version of my study, I would certainly use questions and questionnaires and surveys, so I would conduct a mixed method. But because mine was the first, I wanted to provide rich description. My whole purpose was to simply, from the voice of the participant, and I wanted to provide their perspective. And that's the second strength, is literally I turned the floor over to my participants. I said, tell me, just go ahead and tell me how you perceive aging, and how do you understand counseling for adults. multiple realities, a meaning-making process and perceptions had emerged pretty much organically, not painlessly, because again, this process of having themes emerge is a very laborious one. It's very laborious to go through, but I would do it again in a heartbeat. And free from judgment, I did try to not kind of judge anything that my participants said. They were very candid. Gleaned an age-related perspective not previously investigated. I did have a couple of international students that provided an amazing kind of comparison and contrast to how they view their elders versus how Americans view their elders. That truly is the end of my presentation now. Thank you. Thank you. Questions, comments?